Welcome back, everybody. At this time, we're excited to welcome our esteemed CMS colleagues. We have Dora Hughes, Michelle Schreiber, Doug Jacobs, who I think is online, and Susannah Bernheim from CMS. And I'm going to let them introduce themselves as we get started. And committee members, we have about an hour with them, and hopefully within that time, we'll have plenty of time for questions. And just turn your cards over, and Josh, if you're on, just raise your hand on Zoom. So I'll turn it over to you all.
Thank you. Oh, yep. Okay. Just checking the microphone worked, but it don't have to blast everyone out. Dora Hughes, I'm the acting chief medical officer and acting director for the Center for Clinical Standards and Quality. For our panel today, I thought I would just kick it off, just give a few words about our national quality strategy, and then pretty quickly turn it over to my colleagues who are going to go deep on all of our various issues. And then we'll have some time. We're hoping about 20 minutes, possibly a little bit more for questions and answers. I do have to say, I have to, at the very outset, before I forget, I do have to note that the CMS Quality Conference is April 8th through 10th. We hope that everyone's registered. We are excited that we're going to be back in person, although it will be hybrid. I think last count, we had over 2,000 registrants. And so we intend to fill up the hotel, but also make sure that it's a robust experience for those that have to sign in virtually. All of us will be there. And so we, in many ways, will be able to continue the conversation that we're having here today. So I did have to start out with that plug on behalf of my other colleagues at CMS who would very much want me to make sure I mention that. For us here today, to continue on our conversation, I thought it was very helpful. Our Principal Deputy Administrator, John Blum, noted that for us, given that many of our beneficiaries, certainly already on the Medicaid side, of course, but increasingly on the Medicare side as more of our beneficiaries are getting care through the plans, we have a less direct relationship with providers, less opportunities in many ways to influence healthcare delivery through payment, because many of those decisions are being addressed through the plans. And so because of that, it does even increase even more so the importance of our quality measures, our quality reporting and payment programs. And that is why certainly for us, it's very exciting to see this even more increased interest in all of the work that we do on quality. Historically, it's always been a top priority for CMS, but even more so in this current climate, where we're seeing the trends with our beneficiaries, how they're receiving care. And for CCSQ, since we're going first, I could always note that for CCSQ, if I don't always have the numbers right, Michelle will correct me, but I think if we have maybe 27 different quality reporting programs, 20 of them sit within CCSQ. And so for us, our quality programs very much is a top priority for us at CCSQ, very much our North Star for what we do on behalf of CCSQ, but really across all of the centers with CMS. We also house the QIO program, which allows us boots on the ground to address quality issues across the range of facilities. We also survey. We have oversight over accrediting organizations. CCSQ is very much the lead center for quality here at CMS. And you'll hear certainly more about the work that we're doing. But equally exciting for us is the work that we're doing across the centers. Alignment is, and I think that's very much reflected in the CMS National Quality Strategy, especially as you're thinking, as you're hearing more about the universal foundation measures, how we can make the work that we're doing in quality seamless, well integrated across all of our programs and policies on the Medicare side, the Medicaid side, the marketplace side, is very much has been increasing a part of our focus over the last 2 years. As you know, the CMS National Quality Strategy that was released in 2022, that was our first, I think, truly cross-center effort to really think holistically about our quality enterprise here at CMS. I'm excited to be sitting by one of the main authors of the strategy, Michelle. She'll certainly dive deep. But at a high level, as we stated, our quality mission is to achieve optimal health and well-being for all individuals. And we think it was very important as part of that. It's implicit, and we also try to make it explicit. It's across all of our care settings. And when you think about, as much as we focus on hospitals, increasingly more on long-term care facilities, but that also encompasses whether we're talking about our hospice programs, home health, inpatient psych, inpatient rehab, skilled nursing facilities. I mean, if it's a rural emergency hospitals, across all settings, across the care continuum is a really important part of our focus for the National Quality Strategy. In our vision, I'm just going to read it, CMS, a trusted partner, emphasis on the trust part, in shaping a resilient, high-value American healthcare system that delivers high-quality, safe, and equitable care for all. We have 4 priority areas with 2 goals within each. And importantly, we have objectives and targets for us across each of these areas. The first priority area focuses on outcomes and alignment. I've mentioned the importance of alignment across all of the centers, but outcomes, of course. And that is, as we look across the quality measures, we're looking generally across all of our programs, but we do have some particular areas of focus. Maternal health, of course, is one example, behavioral health, organ transplantation, a number of other priorities that you'll hear more about through our comments. Our second priority, equity and engagement, of course, coming off from the CMS Innovation Center, where I led our health equity strategy that remains near and dear to my heart. And I think true for CCSQ across, our goal has been across all of our programs that we will have a specific focus on equity, and we are very much on track. We are measuring our performance on that, and we think by the end of the year we will have, early next year, we will achieve that, in part through our embedding social determinants of health screening requirements across many of our programs. For hospitals, we are stratifying our quality measure, sharing the findings confidentially with hospitals, other providers. I really hope that if we're able to identify areas of disparities, that this will help to incentivize hospitals, providing TA to hospitals on how they can address. The third area, safety and resiliency, and I'm going to go in reverse. Resiliency, I think, coming out of the PHE has been an obvious area of need, obvious area of focus. But certainly we've signaled that we, even before the change incident, that we are expanding our focus on resiliency, thinking about cybersecurity, thinking about how can we help health systems address issues with drug shortages, another example, climate change. We're looking very broadly across issues of resiliency for hospitals, health systems, other settings, and also thinking about what does that mean for our workforce as well. Safety, of course, we have not achieved our pre-pandemic levels of safety, and increasingly, and certainly even through this rulemaking cycle, you'll hear more about more proposals on other safety measures and initiatives that we intend to lead. And the final area is interoperability and scientific advancement. We have committed that we want to fully transition to all digital quality measures, all digital data collection by 2030. Again, we think we are very much on track to achieve that objective, and we think that'll be hugely helpful in advancing our overall quality strategy. And scientific advancement, certainly for us, in our prior strategy, we noted our new coverage pathway for our coverage analysis group, transitional coverage for emerging technologies, or TCOC. But even broadly from that specific pathway, our specific interests, we are looking very generally, how can we make sure that we are supporting learning health systems? How are we thinking about evidence, more evidence-based approaches, and not only for within CMS, but across our other agency partners, notably NIH and FDA and ONC. And I think you're going to hear more about this broader look about how can we increase and share our data in ways that will advance learning throughout our agency programs and policies. And so with that, I'm going to turn it over to Michelle for the deep dive portion. And again, thank you for your time today.
So it's still morning. Good morning. I'm Michelle Schreiber. I'm the Deputy Director for the Center for Clinical Standards and Quality under Dora. And most of my work is around quality measurement and these value-based programs. So all of those 27 value-based programs, not the CMMI ones, but the general Medicare ones, are those that I work on. And as Dora pointed out, we have done more and more alignment, not only across CMS for our measures, so alignment from CCSQ or Medicare with Medicaid, with SOCIO, which is the marketplace measures, now with CMMI and the model measures. That actually didn't always happen as much as it's happening now. And I'm really pleased to say that we meet weekly because of the CMS National Quality Strategy that's a cross-cutting CMS initiative. We meet weekly to talk about quality issues across all of the centers at CMS. And we've done a lot of work in driving alignment and standardization because we do recognize the challenges of having similar but not same measures. In other words, hypertension's 140/90 in this measure and 130/80 in this measure, and it's 65 and above in another measure. We get that. And so what Doug will be speaking to after this is our universal foundation, where we are trying to create standardized measures that we will drive across all of the programs that we have, which will be the same measure. We work closely now, not only within CMS, but also across the federal government. So we now meet routinely with CDC, AHRQ, SAMHSA, HRSA to some degree, as well as VA, to try and standardize our measures across all of these programs and to do joint measure development. So for example, the safety measures, which are so important, as Dora said, you'll see more safety measures coming out. We're working in conjunction with CDC and probably will be moving many of our measures to NHSN reporting and reporting through FHIR. So we're working more with other agencies so that we are standardized across the federal government. And then on top of that, we participate in the CQMC, the Core Quality Measure Collaborative, which has always been led by AHIP and the consensus-based entity, to try and standardize measures across all payers. Now, it's not easy because I'll tell you, every time a payer signs a contract with a provider, they change the measures because they, I'm sorry, want their dashboards to look good. And so this panoply of measures and having to report different measures is not only a problem within CMS itself, but really a much broader problem across the entire ecosystem. Our measurement strategy really is similar, almost the same, as the CMS National Quality Strategy. Outcomes, equity, the key clinical areas that Dora already outlined. We have 27 reporting programs, again, not counting the CMMI ones, plus public reporting programs, plus the STARS programs that exist for many of these programs. Generally speaking, CMS stewards about 38% of our own measures. In other words, we develop them, we steward them, we own them, we change them. NCQA is about 20% of our measure portfolio, and the rest of the portfolio can be many others: CDC, AHRQ, specialty societies, and so forth and so on. As you noted from the ASPE report, which, by the way, I really enjoyed reading, thank you, it was well done, on measures. We have, again, made this concerted attempt to align, but they aren't always aligned. The MIPS program has by far and away the largest number of measures, and there's a reason for that. It's because the statutory requirements of MIPS said that we had to have measures for every specialty, and we have to have cost measures to cover 50% of Medicare Part A and B spending. So that led to a large number of measures within MIPS. We are trying to standardize that as well because MIPS really had a very large choice. If you were a provider, there were several hundred measures and over 100 improvement activities that you can choose from. And some of those measures really don't get used often enough. And one of the issues that we heard back from providers is that these don't apply to me. And so our strategy going forward, and I'm sure you're aware of this, is what's called the MVPs, the MIPS value pathways, which are basically measure sets. They have all 4 categories of the statutory MIPS program: quality measures, improvement activities, cost measures, and promoting interoperability. But they are themed around either a specialty like cardiology, but within that, it's meant to be team-based. So if you're a nurse practitioner, if you're a PA, but you're kind of in a cardiology practice, these will be for you too. And I recognize all of the subsets of cardiology. There's EP and heart failure and interventional cardiology and so forth and so on. But the broader MVP is meant to have enough choice that any of those specialists can actually find meaningful measures there too. Within the MIPS program, we not only have the measures that CMS stewards, but also there are a number of registry measures that can qualify to be in MIPS as well. So MVPs are meant to be smaller sets, less confusing, more meaningful to the providers who report those particular measures. And they're an important strategy going forward in CMS because we're going to use those intentionally in specialty reporting in ACO programs and in specialty models. And so you can start seeing these themes that will be emerging over the next several years. The first year of MVP reporting, however, was just in 2023. So this is even new for us, but that we're hopeful going forward. And again, trying to align around this strategy. In the past several years, some of the things we've worked very hard on, and not only alignment, but burden reduction. We've decreased our overall measure portfolio. In most of our measures, as I said, being in MIPS, we have reduced that portfolio as well. We're looking at, however, a few gaps that are very obvious. One has been around equity, which I'll address in a moment, and we think we've addressed that. Care coordination is another important topic, and frankly, patient-reported outcome measures. And Susannah may touch on that because she's really leading the agency efforts around patient-reported outcome measures, because we recognize that the importance of the patient voice in really hearing about their care. There were a couple of comments in the ASPE report about measure endorsement and the process of measure endorsement, so I just want to touch on that for a moment. You may wonder, well, why aren't all measures endorsed? And in part, the answer is because it isn't mandatory for all of the programs. So for the MIPS program, for example, that wasn't part of the Social Security Act 1890, that's what talks about endorsement, and the consensus-based entity, MIPS, was actually not included in having to do that. And so some of the measures don't have to go that pathway, although we frequently choose to do it. Most measures, however, follow the standard measure conceptualization, measure development, gets put on the measures under consideration list, which generally opens in May of every year. CMS considers measures, and measures can come from anyone, any source, any entity, anyone can submit a measure to CMS for our consideration. We will call that list, we will make it public, and then that goes to the consensus-based entity, who then holds meetings with what's now called the primer, patient-reported, I'm going to blank on what primer stands for, that's terrible of me. Formerly the measures application process. But it's now a large group of individuals who really weigh in on, are these measures really applicable to the various CMS programs? And so that's very important feedback that we get. That goes into the determination of whether or not a measure will be proposed in a program. If they are proposed in a program, it's the normal rule writing scenario where they get published first in a rule proposal. There's a 60-day public comment period before the rule is finalized. And then after that, either the following year or further in the future, the measure is implemented in a CMS program. The development of measures is not for the faint-hearted. It's about a 5-year process that I just spoke of, from measure conceptualization to where you see it in a CMS program. And frankly, it's frequently longer than that. Although I think our all-time record was during COVID when we got measures in 2 years. Those were the COVID vaccination measures, because there was such a public health crisis that demanded that. All measures are carefully thought out. They have technical expert panels with clinicians and wide stakeholders on them, all have significant input. And again, every step along the way, not just development, but in rule proposal and in the primer meeting, there's a lot of public comment and public input. Dora talked a bit about some of what our key topics have been over the past several years. Maternal health, so we've had a new suite of maternal health measures, particularly around maternal complications in the hospital. We've had a whole suite of measures around equity, the social drivers of health measures, which, again, the same way we're trying to do this for other measures, we're trying to drive them into every single program. For those social drivers of health programs, they started in the hospital and they are now in every program that we have across CMS. COVID vaccination, the one that was most commonly used in the ASPE report, same thing, driven across every one of the programs. And some of the newer measures now, climate change, workforce, drug shortages, these are things that are coming up for the future. And proms, I already touched on a bit. Equity, however, was not just in measures. We've made a concerted effort to really raise up organizations looking at equity. So we have a measure around, are you committed to equity? Are you using your data? Are you stratifying your own data? And then we provide confidential feedback reports. As Dora said, we started in the hospital, but this is a strategy for every program. We've chosen the most important measures, and we're providing information that is stratified now by duals, sometimes race and ethnicity. We're looking at ADI. How do you define a vulnerable population is actually a very complicated question, but we're trying to provide confidential feedback report to facilities. And then we're trying to modify payment adjustment as well. So there's the rewarding excellent care for underserved populations called RECUP or RE-UP, depending on who's speaking. And what that did is we changed the scoring methodology in like the SNF value-based purchasing program or the hospital value-based purchasing to actually award incentive dollars to organizations who are doing well with their underserved population. So we're using it not just for measures, but to also drive payment reform. This is my 2-minute warning. Okay, good. Then I can go to my very favorite topic, which is the transformation of measures in a digital way, because that is something that CMS has been driving now for several years. And I would encourage all of you to be thinking along these lines. As you make recommendations for measures, I would think much more about the future. Technology is changing. Interoperability is very important, and how we get data and can actually look at care coordination for a population is going to be dependent on having that digital information that resides in many places. Most patients see providers not just in a single hospital or hospital system, but in many places. They get their care at CVS for their immunizations and in a community center. And so CMS is really making a lot of efforts to move towards FHIR-based reporting, FHIR API reporting, electronic clinical quality measures, the ECQMs, not without a lot of pushing and screaming along the way from virtually everyone in the ecosystem, because this is change and this is work. But if you look at the Hopkins article in JAMA a few months ago, it is clear that electronic clinical quality measures are cheaper, much more efficient, much less burdensome by orders of magnitude, compared not only to measures that are chart abstracted, but even claims-based measures. And they're the only measures that can capture the rich information that's in the electronic medical record. And so we really need to think along those ways. And what does that take? That takes standardized data elements. We work closely with ONC and the US CDI and US CDI Plus to identify standardized data elements that we can be using in digital measures. And we have to be growing interoperability, such as through health insurance, such as the HIEs, the Health Information Exchanges, and TEFCA. The advantage of digital measures is, first of all, the capture of all of this data, the reduction in burden, but that we can leverage them for advanced machine learning, AI. You can layer on advanced analytics to this. You can provide real-time results. I mean, our measures are old by the time people get them, but for electronic measures, organizations can use it at the time that they collect it. They can use it tomorrow, for example, for a safety trigger tool. And finally, providers then need more information. They need cost information, for example, and payers and providers need closer linkages so that they can provide that. We need standardization, as I pointed out, and the overall transition then to true interoperability. Speaking of standardization, now my 2 minutes are probably up. I'm going to turn to Doug Jacobs, who is the Chief Medical Officer for Transformation for the Centers of Medicare, to talk about the Universal Foundation and our attempts at standardization. Doug, I think you are on the screen.
Great, thanks. Can you guys see me? I can't see myself, so okay, as long as you can see me. Hey everyone, it's great to be here virtually. Sorry, I'm not here in person, but happy to talk to you about the Universal Foundation. I'll try to be a little bit quicker with my portion, so we still have time for Susannah and questions after that. As Michelle and Dora mentioned, over time there's been a proliferation of quality measures, and in many ways that's a good thing. We can measure aspects of our healthcare system that we could never measure before. And we have intricate looks into different types of quality measures with all sorts of facilities and in outpatient settings. And on the other hand, as we've had more of these measures proliferate over time, there's a tension there in that simultaneously it adds administrative burden if there's lack of alignment. And so part of our effort to really align these measures across the different centers within the Centers for Medicare and Medicaid Services, so Medicare, Medicaid, the marketplace, and really think more cohesively about these measures has been the development of the Universal Foundation. And so it's the Universal Foundation as a concept has been out for more than a year now. And the idea is that there's a universal set of, or CMS will put our stake in the ground for a universal set of quality measures to use across as many quality and value programs as is feasible. And when Michelle mentioned that we have this quality working group that meets weekly, we really did this across our different centers and the selection of these measures to really align behind these measures where we thought that we could conceivably align even better in the future. And so when thinking about these measures, we tried to select measures that made a meaningful impact on patient outcomes, that also were either digital now or capable of becoming digital in the future. Michelle touched on our overall digital measure strategy, and we thought that that was an important piece as well. Also, the measures are either able to be stratified now with known gaps that point to disparities, or they're capable of being stratified in the future. And so these are measures that we could prioritize more for developing stratification methodologies going forward. And finally, we were trying to select measures that had no unintended adverse effects. Sometimes, for example, when you screen for something more, you end up doing more procedures that might be unnecessary. So we're trying to figure out ways that minimize any harmful effects of potential measures. And so last year, we published the Universal Foundation in both adult and pediatric settings. And these measures also focus on cancer. Cancer moonshot is an important goal that this administration has. So there's measures related to breast cancer screening, colon cancer screening. There's behavioral health measures that in both adult and pediatric settings focus on depression and substance use disorder. And there's also measures related to preventative care, chronic disease management, hypertension and diabetes, and coordination of care. And also, finally, patient experience measures through CAPS. And so this is the first iteration of the Universal Foundation, and we've gotten a lot of feedback from folks over time. And now that we've come out with the Universal Foundation measures, and we've also demonstrated progress towards alignment as well. So Michelle touched on the MIPS value pathways, or MVPs. The MIPS value pathway for primary care has now all of the Universal Foundation measures in it. And we made that change last year. Also, we've solicited comment in Medicare Advantage and the Medicare Shared Savings Program. in getting to these measures over time. And there's been some changes made as well to move to the Universal Foundation in Medicare Advantage. And also on the Medicaid side, there's a lot of alignment already with these measures, which is great, both in Medicaid managed care and outside of it. So as we think, and also the marketplace too has great alignment with the marketplace quality rating system. So I have the pleasure of being the co-lead with Susannah and Michelle on the National Quality Strategy. And so collectively, we've worked towards building towards the Universal Foundation. And I think that going forward, some of those goals that we have in prioritizing these measures for digital transformation, for stratification and observation of like inequitable care gaps, we're taking the next step in those areas as well. So I think with that, be happy to talk about the Universal Foundation more as we could get into the discussion portion, but maybe I'll turn it over to Susannah to go over her portion of the talk. Thanks for having me.
Hi, you all got to hear from me yesterday, but I'll reintroduce myself. I'm Susannah Bernheim. I am the Chief Quality Officer and Acting Chief Medical Officer for the CMS Innovation Center. I'm just going to spend a couple of minutes talking about how sort of we think about the quality strategy within the Innovation Center. I'll mention again some recent work on our new quality pathway, which is an internal initiative to elevate our focus on quality outcomes and experience at the center. So first, all of the work we do really sits in the context of two things. One is the statute that created the Innovation Center, which tells us to look at alternative payment models and think about both reducing cost and improving quality, and our recent 2021 strategy refresh. And that the objectives of that strategy refresh focused on accountability, on equity, on innovation, on affordability, and on partnerships. And as part of the document that we put out, we really declared an intention to broaden our vision of what success of our models is. There's been historic focus, understandably, on reducing spending, but we wanted to very purposely step to thinking about models improving based on the impact on transforming care for the benefit of patients. So our quality strategy sits in the context of both of those pieces. And one of the other things is that we realize it's not just about the quality measures in our models. The models have the opportunity to influence and improve quality in a number of different ways. So I'll talk about that as well. And then finally, we described in a New England Journal of Medicine Catalyst piece last fall that we also want to increasingly use the models to understand in more detail how care gets better, how to use the models as a test to understand how care redesign can really make improvements for patients. So with that backdrop, how do we decide what quality measures to use in one of our models? And I think first and foremost, we are focused on determining the primary improvement goals with a focus on outcomes and experience for that given model. Our models are quite varied, right? Sometimes we're looking at small primary care practices. Sometimes we're looking at large ACOs. Sometimes we're looking at the work of nephrologists. So for every model, there's distinctive and different participants. Sometimes it's a state Medicaid agency. So we want to ensure that each of the models has a primary goal and an aligned set of strategies driving towards those goals, focused on the benefit to the patient of this model, but also noting that the quality measurements are just a piece of what we can do to drive that. And we have to really think about that measured entity. This has come up in the conversations you guys have had, right? It's a very different world in terms of quality measurement, depending on who's being measured, where they're accountable, what quality measures they're already held accountable for in other contexts. So we're thinking about that as well. We're thinking about alignment with MIPS. So as we build a quality strategy for our model, to oversimplify, once we have our kind of North Star, we first look to identify familiar, low burden, aligned measures. We look to the Universal Foundation where it fits into the model's goals. This alignment with the Universal Foundation, you'll see particularly in like our primary care focus models, where we're also thinking about multi-payer alignment. For instance, our Making Care Primary model, you'll see a lot of lineup with the Universal Foundation for those reasons. But we are also able to and looking to broaden the use of outcomes and experience measures. And as you've heard, we have a particular commitment at the Innovation Center to the use of patient-reported outcome measures. If we fundamentally want to drive towards more person-centered healthcare, the voice of the patient is really critical, and you've heard that from many of your speakers in the last day. And we understand that these are not easy to implement. So we're often introducing those new measures, sometimes in a pay-for-reporting context. We are often providing tools to support participants in the data collection. Our learning system is supporting participants as they build the infrastructure to collect these tools. And then when we need to, we build new measures. So we look to have aligned measures, we promote outcomes and experience measures, and we build new measures, like the days at home measure that you heard a participant talking about in the ACO REACH model. We've built a measure that looks at the time to dialysis in the context of our kidney care choices model. That's a really important patient-centered outcome. And in the new dementia model, guiding an improved dementia experience model, we're going to be looking to build a new measure looking at the stress and strain on caregivers, because that's such a central piece to what we're trying to improve in that model. And then finally, as a small component of really a very broad equity strategy in our center, which Dora is the architect of, for an increasing number of models, we are directly providing participants with stratified data to help them look at disparities in the quality measures that we're using. So when we build these strategies, and people have been talking a lot about a portfolio, we're really thinking about competing but important aims of burden and alignment, of driving new measurement tools, and thinking about outcomes and patient-reported outcomes. I'm going to say just a couple more words really about how what we're doing differs and complements what's happening in CCSQ and CMCS. As you know, there's a lot of important quality measurement programs that are built out of CCSQ, and we have a very strong collaborative approach, as you've also heard. We meet often and enjoy that. And so all of our work is also sitting inside those overarching goals of the National Quality Strategy, and we're driving towards similar outcomes measures, digital measures focusing on equity. But what's slightly different for us, and what I hope your recommendations can help us with, is that we aren't setting measures into predefined programs. We have a lot more flexibility. We need to tailor our measurement strategy to distinctive participants with distinctive goals. And as I mentioned, there's also other tools that we have to drive improvements. We want to think about how we take advantage when there's a waiver, or what our learning system can do, or multi-payer alignment. And we think about the quality strategy as really just one component of how we're improving things. Also important is that commonly we are putting out voluntary models. This means we really are accountable to having a measure design that makes sense to providers, that they feel is meaningful, that they want to join us to participate in. And we have a lot of flexibility in how we use measures. I think our next panel is actually going to speak to that a little bit. We can think about how to build benchmarks. We can think about how to introduce accountability. We can test measures without going through the processes that are required for CCSQ. So we have a little bit more of a nimble context. So we can really think in building our portfolio of measures, how to take advantage of those flexibilities and introduce things. And then we need to think about how we're building things that can be used more broadly, because this focus on alignment is crucial, but we're doing it a little bit retrospectively. So the other thing we're thinking about in the center is, are we building things that might have use in the future in other contexts? Can we be a tool for the agency as a whole to think about novel approaches to measurement? So that's a lot that's on our mind when we try to build a quality strategy for our new model, and we're really looking forward to your recommendations. As I mentioned in my opening remarks yesterday, we're really in the midst of launching an initiative at the center called the Quality Pathway, which further sort of articulates and strengthens our focus on quality outcomes and experience from the earliest part of model design through evaluation. And there's more coming at the Quality Conference. You'll hear from us about that. That's April 8th through 10th, and in a publication that's forthcoming. But it centers on this concept of building aligned pieces of our model towards central quality goals, focusing on outcomes and patient-reported outcomes in particular, and patient experience. And then finally, we're also thinking a lot about how to design our evaluations so that we can really assess the impact we've had on those quality goals, so that we can not only support quality improvement, but evaluate and disseminate successful strategies. So thank you for your recommendations that are forthcoming.
That was great. I appreciate all that information. So we're going to open it up to the committee members for questions. I'd like to start out with one. I think, Dora, you mentioned in your conversations about interoperability and scientific advancement, a willingness to share data going forward. And I wanted you to comment a little bit more about that. And so is that more about process improvement, or are you willing to share de-identified data for large scientific exploration, or what are you thinking in that regard?
So I think for CMS, it would probably be a both and answer. And I think even starting, especially true for a CMS Innovation Center, historically the data was kind of locked. We used it for evaluation, and then that was that. We're trying to think more creatively. How can we use the data internally, but also share it with our external stakeholders? That can only help us. We have bandwidth, we have financial issues. If we have colleagues externally who are willing and able to do additional analyses that even target issues that we're not able to address, that can only help us as well. And also just have an external set of eyes validating the work that we're doing internally. So that's on a narrow but really important path that we're on. But broadly, and I will give credence to our colleagues at NIH and FDA who are thinking big, very, very big. Like how can we all use our various, very large data sources across the federal government, almost like a whole of government approach to really work through whatever intractable issue or challenge that the various agencies are facing. It's part of I think at least the internal name is the EVGen Working Group Evidence Generation, but I think ONC is also part of the spearheading this initiative, came up with the cooler term, I think. And so that is an effort that's really moving out of conceptual to, and if we were to do this, what would be required? So at this point, I can't give more specifics, so they truly don't exist. But we've had really senior leadership buy-in. We have committed folks who are working on it, and I think, there's just a lot of excitement to think through how truly can we work across these huge operating divisions to use our data more productively for all of our programs and policies.
Thank you for that. You do have rich data, and that's exciting to me. We've always wanted access to be able to learn a lot from the data you have. So I'm hoping that comes to fruition. So thank you.
And can I just add specifically, just because I think it's really important for folks to know that a few years ago, there was a decision to try to make it possible for folks to look at all of the models. And so our business services group has been in the process of model by model putting out, I think you can get it through ResDec, you probably know better than me, so you can see who was participating in the model, and that allows researchers, exactly as Dora said, to take their own look at what the evidence is that's generated by the models. I think we're up to 20 models now that are available through that process.
Great, thank you. Jennifer?
Thank you so much for giving us this opportunity, and we're so excited about all of the great change you've described and that's forthcoming. My question is going to be around much of what we've heard, not only through this meeting, but through previous meetings from the stakeholder community, is around the importance and yet challenges around coordinating care. And although that is implicit in everything you've described in terms of strategy, we've heard some recommendations about very tactical levers that could be used to improve that coordination, including in our last session, requiring or creating a metric around sharing of information, specialist to primary care, inpatient to ambulatory setting. So my question is around how are you thinking about care coordination and the very big levers that you all have to incent what we know from an outcomes perspective is good care delivery, and from a value perspective, more cost efficient?
I think one of the themes you'll hear is it depends a little bit on what authority we have and what we can do, right? So in the context of broader models that cross multiple settings, I think you can get at some of that by measures that, and this again came up a bunch yesterday, by measures that sort of hold many different entities in different settings accountable, right? So when we have a bundle, you start to by design create opportunities for coordination and hold folks. I think it's harder when we, and I think you mentioned this too, Michelle, we sort of have looked for this magic individual measure that says, oh, my care was coordinated. And I don't think there's a single measure that does that. I think patients have a lot to tell us about that. So I think patient experience is really important, right? You know, some of these measures ask questions like, does my practice know me? Things go about. I think there's places in the world of diagnosis that we need to really get better at coordination. And there's a lot of work going on for those measures. But again, it sort of depends on whether you're in a context where you can look across entities and hold a system accountable versus an individual or a given institution. That's sort of how I think about it.
Yeah, thank you. It's a really important question, and it's very complicated, as you're already pointing out. Completely agree with what Susannah said. What ONC, CMS, and others have been trying to do is to ensure that exchange of information, right? You're both promoting interoperability. Virtually every program has in it the exchange of information. So in other words, the release of information to the next provider, the release of information to the patient, information blocking rules that came from ONC. So all of that infrastructure is trying to be built. And now it's a matter of making sure that people do receive that information within a model or within a shared approach to taking care of a specific population. You can hold people accountable for that a little bit more easily than you can by individual facilities. We have, proxies for care coordination, which is like readmission, which isn't the greatest, but we recognize that was the attempt at care coordination. And we're starting to be explicit in some measures about the exchange of information, the time to consultation, the time to somebody seeing that. But I think some of this in the end may have to be patient-reported outcome measures and their perception of the actual coordination of care.
And I maybe just wanted to add one thing from our perspective in the Center for Medicare. So even beyond the world of specific quality measures, what we pay for and both inside and outside of value-based care models and programs can be really important in driving care coordination. So over the last 10 years or so, Medicare has started paying initially for transitional care management, which essentially pays more after the follow-up of inpatient admission to an institution, of doing that work of trying to understand what happened during that inpatient admission, and then in an outpatient setting, making sure that we coordinate effectively, all the medication is right, that there's no barriers to the treatment plan. Additionally, we have the chronic care management codes, and actually just this last year, we finalized new codes for community health integration and principal illness navigation. These are primarily for patients that have unmet social needs that affect the diagnosis and treatment of their medical problems, or in the case of principal illness navigation, have some kind of high-risk condition. And that also involves care coordination, and are the first codes that were really designed to describe services performed by community health workers, peer support workers, and other care navigators. This builds on the care management history that I mentioned earlier, and we've seen over time that patients who get these care management services do have less readmissions. And so that feeds back into what Michelle and Susannah were talking about too, in that when patients are receiving this kind of coordination of care, we can see it in the readmissions measures. It's not the end all and be all, but it's an important indicator.
It's going to be a challenging question, but it's mulling over in my head, so I'm going to see if I can get it out. Sometimes I sit in the PTAC meetings and I think of all our colleagues out in the field. We just heard a couple in our meeting, and we've heard this before, but and I guess the thing we think about as doctors is this idea that our colleagues, the profession itself and the colleagues within the profession are feeling pretty burned out, and that the profession itself is underperforming maybe as on quality as a consequence of that, right? Having run a large physician network that are independent, my primary care doctors, as an example, made more referrals when they were more burned out, right? They're so frustrated with the administrative load that they were doing in the ACO that we were bringing to them. So I guess one of the things I think about as a PTAC committee, when we get together in our kind of private conversations as a committee, one of the things I think that comes up for me often is this idea of what would we say to our colleagues as we went back and took back the message of what are we able to recommend that would help you guys do your job representing us, that we could then say out to the community, I think we're making progress in reducing your burnout by the burnout that's being caused by quality measures or quality documentation or your frustration with the interoperability. You know how bad that is, right? I mean, you'll know this. And so it's almost like there's a message that needs to go out as a collective of us, the people who are in practice and people that are dedicating their lives like you guys are as physicians to doing something for the profession, which then ultimately produces better quality for patients, and it's safer. The beneficiaries are benefiting, and the patient-reported outcomes are better. So I'm curious if we could actually write that script out. What would that sound out like from each of y'all? That you would recommend to us to recommend to y'all? So you get the idea. All right.
Well, in some ways, it's starting from reverse. It's not directly, but I think even what Doug just mentioned, that we are establishing codes, we are starting to pay for, and the context of the question was on care coordination, bringing in others on the team who could in at least in theory, lighten the load. And I think that's is proving to be the point. So I do think being more direct, tying the payment to what we're asking physicians can be helpful. I also think on the quality measure side, and we're hearing more and more, I don't know how much of it's recognized on the inside, but even, I think there was a pretty, we were taking a hatchet to the number of measures. And so we're certainly not doing that, but still being very thoughtful about which of these measures, frankly, are not driving quality, which ones are tapped out, which ones need to be removed. And so knowing that continues, I do think that we need to do a better job in some cases for some settings, understanding where we may need to do more, accelerate. But I do think that we have continued to have a heightened sensitivity to the issue of burden. And also, we don't talk about as much, and I also wonder for a future session if our colleagues, I don't know if you've heard from our colleagues in OBRI, Office of Health Burden Reduction, Health. You get lost in the acronyms, but even just hearing some of what they were able to do, for example, with the prior authorization rule, that was, you don't often hear OBRI, but in fact, they are leading some of the work in direct response to what they're hearing from providers, and of course that's. OBRI doesn't act alone. Of course, it's working across the centers, but bringing us together to think through. And I think even if we thought about it more, I have no doubt there's a number of other examples that we would want to add to the list. So maybe I'll turn to Michelle to hear what some of your thoughts. Then and Doug.
So I guess my number one recommendation would have to be accelerate the digital course of measures.
Yeah.
It's clear that these are the most efficient measures, the least burdensome measures. They're not least burdensome to begin with because there's work to map your workflow to this. But once that's done, the data can flow seamlessly from clinical care, where the provider doesn't necessarily feel like they're just a data entry clerk. which is part of the problem right now. Make electronic medical records more user-friendly, I think is critical to part of this as well. And then the interoperability of data. Healthcare has been slow to the digital transformation compared to many industries. I think we all know that. We all recognize that there are multiple barriers along the way. But the end goal of interoperable data that can be shared and used, that can ultimately inform better patient care, that can be used in a real-time basis at the level of clinical decision support, is tied to clinical guidelines. And that is the ultimate goal. And frankly, the further we can break through the barriers and get there, the better I think we'll all be.
So for fun, I'll add a few more. Actually, Doug, it's hard for us to see you, so let me pause and see if you want to add anything before I do.
Sure, I can add a few things. So I agree with what everyone's said so far. I think in the quality measure space, it's interesting. It's I do think that identifying a universal foundation and moving towards there will make a meaningful impact on burden, and agree with everything else that's been said. I want to double down on something that Dora said in the prior authorization space. That leads to a tremendous amount of burden. And this, the rule that recently OBRI, the Office of Burden Reduction Health Informatics, came out with, provides not just for prior auth reform, but also in the way that providers access data. So if you're in multiple value-based care arrangements, and like you as a provider need data from all of them in order to know like the entire patient population you see, it is tremendously burdensome to go one by one into patient portals and to access that data just for that one payer. Because as clinicians, we don't really think all the time about what payer is paying for this patient's care. We think about this patient's walking in the door and what can I do to help them. And so I think that's important. And on the Medicare Advantage side, we've made new requirements that went into effect this year to make Medicare Advantage prior authorization no more restrictive than traditional Medicare, which should hopefully make a big difference in the prior authorization space as well. I think that, and this the last, I don't know how to exactly capture my last thought here, but there's, I think, an element of clinical practice that is more about like the joy of seeing patients and practicing medicine that can't always be widgetized or captured. And I don't know exactly how to put it, but I think it has to do something with training and like what people find joy in their daily work, and whether they find their work to be a calling or more of a job. And I think there's been some work in this space, but I'm not intelligent enough to speak on it or know what our levers are here, but I just mention it for maybe some further exploration.
So I think all of the things of sort of reducing the burden of the measures, moving towards digital, thinking about what we're paying for. And the only thing I'll add, particularly in the primary care space, that I think we're doing, but we need to continue to do, is that we now have 3 models that purposefully, are expanding investment in primary care. And I think that investing in primary care and creating flexibility for physicians to practice in a different way is going to be key to addressing some of these issues as well.
I'll remind the group that we're at time, but we're having great conversations. I'm going to turn it back over to Larry. I think you had your card up.
Thank you very much for this detailed presentation. I really enjoyed it. The one word I didn't hear is attribution. And it became a huge problem in MIPS. And what are you doing to wrestle with that word?
Attribution is something that we think about often because it comes up certainly in the cost measures, it comes up in the quality measures, but really in the cost measures even more. What provider actually can be held accountable for X, Y, and Z, either the quality or the cost? This gets discussed endlessly in the technical expert panels, and people weigh into this. Is this ICD code included? Is that one? Is this provider included? Is that one? And it's a tough conversation we try really very hard to be as focused as we can for attribution. But in the end, I think there has to be some shared understanding among providers that we're all in this. Take tobacco cessation, for example. The dermatologist doesn't want to be attributed tobacco cessation, right? That's not what I do, they say. Well, is that true? Do we as a collective have some greater good calling that all of us should be accountable to? I don't have an answer for that. But I think it's part of the question that we have to address too.
Sure. I'll be brief. Appreciate the great discussion, and I'm relishing in the opportunity to, for one brief minute, bring something to the top of your inbox and get to your attention, which is focused squarely on first and second national quality strategy priority areas of promoting aligned metrics and advancing health equity. And that is the huge variation in data sets required for race, language, ethnicity reporting among CMS's portfolio of programs. MA is using the expanded OMB list, whereas ACA is using the simple list. State Medicaids are using about, 24 different lists. HEDIS is currently using the simple, but in a hypertension change recommendation form working its way through the system, they're moving their RLE data segregation for the hypertension measure to a wholly new cloth list of RLE reporting that's not either the simple or the expanded list. And this plays out, that level of variation is just going to sow confusion and distrust every possible which way. So I would invite the hatchet to come to RLE reporting. Any of them could work, just pick one.
So not a great response, but that certainly is something that we are mindful of as CMS, all of us that you're seeing here, plus the others, including our colleagues in Office of Minority Health, but across all that Medicaid are very much aligned and focused with your comment there.
I would only say my guess is that within the next year or so, you will see a recommendation for standardized data across HHS. Mm-hmm. It will probably follow what's being done in the Gravity Project, and going through US CDI. So I think that time is coming, but you are right, it is not here yet.
Well, I want to be respectful of our guests' time and just tell you how much we've appreciated you coming and joining us today and sharing this information. Very exciting, big work. So we thank you, and I think we'll adjourn this meeting for the moment, and we're going to take a break now from now until 1 o'clock, and we'll be back at 1. Thank you all.
Produced by the U.S. Department of Health and Human Services.